This is air emphysema that is associated with these orbital blowout fractures on patients who try and blow their nose. You can see that there's restricted movement here. We're asking the patient to look up. His left eye goes up, his right eye does not. Same thing here. Left eye goes up and out, right eye is stuck. And this doesn't mean that he can't see. It just means that he will have double vision, because if he's looking in that direction, he's going to see two different images. All right. Remarkably, globe injuries are not that common with these bony fractures. All right. And part of the reason that the bone is so thin is to protect the eye bone. So if you have an injury, the bone breaks before the eyeball is injured. So that's a good thing, but we still need to fix it so that they don't have double vision. Don't try this at home. This is what's called a forced duction test. You can do this with local anesthesia. Patients get pretty squirmy about it, but most commonly we do it once they're asleep. So you grab the conjunctiva near the iris and try and move the eye in all directions. In this case, we're pulling superiorly and it's not going. So when it doesn't go, it means that we have a condition called muscle entrapment. So that muscle is stuck in a fracture line, and we have to free it from the fracture line for the patient to be able to move his eye again. Other things we commonly see with orbital blowouts, you will see blood covering the conjunctiva. That is not a serious problem at all right? Not an issue for these patients. It may take a while to resolve. It looks kind of weird, but it is completely not a concern, all right? So on the other hand, on the right image here, what we see is a hyphema, and the arrow shows the superior aspect of that. That dark area over the iris is actually blood in the anterior chamber of the eye. These patients we try and keep upright so that they do not have that blood settle out over the lens, which will restrict vision. All right, so this is a concern for us. So we have subconjunctival heme on the left image, so the redness is just blood that will be resorbed by the body in a period of a couple of weeks. But the hyphema is something we really need to keep an eye on, and we usually have the ophthalmology guys see these patients and manage that. So how do we get there? Usually we make an incision either in the lower lid or inside the lower eyelid so that there's no skin incision. If we make it in the lower lid, we tend to have a little better access to the orbit, and especially with a larger fracture, we want to be able to remove the contents from the sinus. So it's mostly orbital fat that's down in the sinus, but even if the fat gets stuck, it can impede muscle function. So what you're looking at in the left image here, that the orbital floor is missing because it went down into the sinus. So we're lifting all that orbital contents back up with a retractor. And in the right image, that's a thin collagen sheet, which will ultimately resorb, and there will be some scarring, but that will allow the globe to be supported. And once it heals, the patient will have normal function. You can also do it with plates. This is another patient. These previous two patients are ones that I did not that long ago. You can use plates as well. They are not resorbable, obviously. One of the issues with plates, sometimes if you get scarring over the plate, it can actually restrict globe movement. So my personal preference is to use the collagen if I can, but for some bigger fractures, you may need plates. Zygomatic arch, called a gull-wing fracture because it looks like a bird with flapping wings, may have a cosmetic defect. It also may have a functional defect because if the zygomatic arch is displaced medially, it will impinge in some cases on the coronoid process of the mandible. The patient may not be able to open their mouth. This can be done by closed reduction, essentially not treating it if it's not very displaced, semi-open reduction, or rarely by open reduction. So here's a guy I treated a lot of years ago, and you can see that he's got one of these fractures of the zygomatic arch. Actually had impinged on his coronoid. He couldn't open his mouth, so it needed to be reduced. So when we do this, the red lines illustrate the superficial temporal artery, which splits at the superior aspect of the pinna. One branch goes anteriorly, one branch continues superiorly. We want to make an incision above that artery. You can often palpate it, not always, but usually. You make a small incision up there and slide an instrument through that incision right underneath the zygomatic arch and pop it out laterally. Sometimes we will put a little orbital shield over this so the patients don't lie on it and push it back down. This is a fracture you'd like to try and fix sooner rather than later, because if after 5 or 6 days, the fractured bone edges start to remodel and they won't click back into place like they will oftentimes if you do it sooner. Zygomatico-maxillary complex are sometimes called tripod fractures, really 4 fractures, not 3. It's a zygomatic arch, lateral orbit, the inferior orbital rim, and the maxilla. Oftentimes there's a blowout component in the orbit to this as well. CT imaging is always best for these. You can see it on plain films, but CT is better. We want to think about cosmetic outcomes as well as functional outcomes. Remember, if we have the orbit involved, we don't want to restrict eye movement, but if these fractures are impacted posteriorly, which they often are, it can lead to a pretty significant cosmetic defect as well. If it's significantly displaced, you may not be able to do lateral excursions of your mandible because the coronoid impinges on the zygomatic arch, and you won't be able to open widely. Your eye movements will be restricted in many cases, and the infraorbital distribution will be anesthetic or at least altered in sensation. This injury is sometimes seen, we see bouncers in bars when they stomp on somebody's face, which seems to happen fairly often around here. You see this kind of injury. So here's one where you see there's a zygomatic arch fracture. You see the sinuses in multiple segments. And if you compare the zygomatic buttress on the patient's left side to the normal right side, you see it's posterior by almost a centimeter. So that's going to be a significant cosmetic defect. Lateral orbit is typically fractured, and the zygomatico frontal suture area is also fractured in many cases. Some of these, if they're not displaced, don't really require treatment. You can do it with the same approach that we did for the zygomatic arch alone, a semi-open reduction. That can also be done right by the lateral aspect of the orbit. So an incision in the superior part of the orbit and slide an instrument behind the zygoma. We can do an open reduction, either extraoral, intraoral, or both. And if the orbital floor is significantly fractured, we probably want to explore that and repair that at the same time. So here's a tripod injury on a kid. This was a dog bite. Do not give your kid a towel with a knot in it and tell him to go play with the pit bull, right? Not a good plan. So this is a situation where you got to clean it up. So the kid's already asleep. I'm going to clean it up first and see the extent of injury. We don't know at this point if there's an avulsion component or not, but once the area is cleaned up, we get a good look at it, we'll know whether we have to replace tissue or whether all the tissue is there. So the imaging, this is plain film. This was considered an urgency. We didn't have time to do a CT scan. What you see